Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Hello and welcome to this episode of the Long COVID podcast. I am so excited to have Dr Meg Anderson back with me today. So we spoke quite recently in our previous episode where we talked a load about exercise and movement and kind of how to know if it's appropriate for you. So that's a really interesting conversation that I would totally recommend you checking out. I'll link it in the show notes, possibly before listening to this one, or certainly as well as. So today we're going to talk a little bit more about, well, how do I actually do that? What does that look like for you? What does that look like for me? And, you know, some sort of things to look out for, I think. So welcome back, Meg.
Hey, thanks for having me back, Jackie. Yeah, it was so interesting after the last episode that we did. I think we both had that sense of like, man, there's just so much more, right? And I mean, we could say that about anything with long COVID. There's just so much more, but there was definitely more to this, and really want to make sure people have a practical understanding, especially in a world when this topic is so controversial, right? Because there are people who benefit from exercise in certain moments and people who don't tolerate it. So really good to just put a little bit more context in. And like you said, we already spoke before, but if some of you are catching this and you haven't listened to the previous episode, as Jackie said, my name's Dr. Meg Anderson. I'm a doctor of physical therapy in the United States. I've been practicing as a PT or a physical therapist for over 10 years, and since the pandemic started, I've been working with severe acute COVID cases in the hospital, and then eventually transitioned to working entirely with just people who have long COVID. And so I've been doing that for over 3 years now, and doing entirely virtual and remote to provide this help for people. So this has become my bread and butter, I guess you could say.
Yeah, absolutely. I agree. And I think it's a really difficult topic because, I mean, you could again say that about every topic with long COVID because everybody is so different, and what one person can tolerate isn't necessarily the same as what another person can tolerate in terms of breathing exercises, nutrition, literally anything. But obviously here we're talking more about movement and how to know that that's something that's appropriate for you, or when to notice that that's something that's appropriate for you, I guess.
Yeah. So I think you hit the nail on the head when you said when it's appropriate for you, right? And that's kind of what we spent a lot of time talking about in the last episode, is that knowing how to get ready for movement and exercise when it's right for you, and kind of these pillars that need to be hit before getting there. And we, just briefly, in case you're catching this before getting to that one, we talked about, metabolic needs, so nutrition, pacing, medical stability, and breath training kind of as the foundation. But here's the thing, like once you kind of get that handle and you feel like, okay, I'm in a place where I think I can move more, or I think I want to try moving more in some intentional way, because that's really what exercise is it's intentional movement with a purpose. The number one thing that you really need to know is that you need to know if you have post-exertional malaise, and I think that's an important concept that not everybody fully understands or learns right away, or it takes a little bit of time for them to realize. And we'll talk a little bit around that kind of understanding the post-exertional malaise component. But one thing I wanted to say up front is that when it comes to long COVID and even post-exertional malaise, I think there's a lot of talk that, or maybe fear around, if you have PEM, it means you can never exercise. And that's really not the case, okay? Because like I said, right now may not be the time for you to exercise, but it doesn't mean never, okay? And I think that's an important piece to really understand, is that, right, yes, now may not be the moment for you, but it's not off the table entirely, right? I think there are still ways that you can optimize your body to be able to then be ready, even with post-exertional malaise, to incorporate movement. And then, that was kind of what we were touching upon in the last episode, but then also just understanding how movement can help post-exertional malaise when done appropriately. So, I think that's kind of an important piece to say, is that, again, there's a lot of talk that it needs to be like this black and white. If you have post-exertional malaise, black and white, you can't exercise, boom, done, right? And it's a lot of gray area, which makes this tricky.
Yeah, I think you're right. And I don't know if I'm totally taking us off in a bit of a tangent here. Well, I mean, I almost certainly am because it's me. But I mean, post-exertional malaise, I mean, we're obviously talking with long COVID. This is something that no one, when you get long COVID, you will never have experienced this before, where, it's completely in proportional to the activity that you've done. So, for example, you climb your stairs and it puts you in bed for a week. That is not a normal reaction. But also, and this was something that I kind of had to work through as I was coming out of long COVID, that actually when you do something, especially if it's something that's a little bit more than you've done before, then you are going to notice, your body is going to go, oh, okay. So, if you are increasing your activity, you are going to feel more tired. So I suppose maybe what to work out in the problem is my reaction to this activity proportional or not? And what does that look like for different people? Because it's not always going to be the same. And is it a problem or is it not? I suppose that's got to be something to think about.
Yeah, absolutely. And I think that kind of touches upon, again, what I mentioned in our last episode, is in order to kind of find that medical stability and being ready for movement and exercise, is really having a foundational understanding of your current response to anything or activity, and really knowing your body and getting in touch with it to understand, okay, I have post-exertional malaise, right? And we can talk about what that is. If you're like, well, what is that? I don't really know. I'm just tuning in. What is that? But I have post-exertional malaise. So when is my onset? Is my onset 12 hours, 24 hours, 2 days later? When is my onset? So I know what my window is and what to look for. When does my post-exertional malaise peak? Because some people, okay, it starts the day after, but maybe it doesn't peak. It keeps increasing and until day 3. And then it starts to tail off. And then, okay, then how long does it last? Oh, okay, I know that usually about 6 days is the course that it takes. Okay, and then I'm kind of out of it. So I think that's really important to know and understand, because then that helps with self-monitoring. Whenever you're introducing anything, any activity, whether it is some form of natural movement or a little bit more of structured formal exercise. And again, like I said, coming back to, well, what is this post-exertional malaise, right? And I think you and I live in a world where we hear it all the time. So, it's like, well, duh, like, yeah, of course. But, there are plenty of people who are coming into this that, maybe they just had their 4th infection and now they're getting long COVID, or maybe they're just getting long COVID, or maybe they've had it and they haven't had the knowledge and the information, and now they're starting to put it together. So to really understand it, like you were saying, Jackie, it's an abnormal response to an activity, meaning it's like out of proportion, right? So you would think, if I ran a marathon, I should feel like really sore, really exhausted, like really sweaty, and like, like I really exerted myself. You shouldn't feel that way when you're doing your normal daily activities, right? That would be extreme and out of proportion. So that's kind of what we're talking about. So some signs or some things that people can experience for post-exertional malaise is extreme fatigue, right? And the thing about it is you might feel fine totally in the moment, and I think that's what's scary for people with movement and exercise is they're like, but I felt fine, right? Like I didn't feel anything. I felt fine. It felt good. And then later on or the next day, I could not get out of bed. I could not keep my eyes open. I could hardly hold my head up. I was so wiped out, right? So there's that version. And because there's a delayed effect. But then there's also the version of which is post-exertional symptom exacerbation, or PESE, right? And that's where, okay, yes, there's maybe this fatigue component as well, but you might have a flare in a whole host of symptoms. GI upset, so like maybe you're more constipated, or maybe you're having bouts of diarrhea, or maybe your breathing changes, you're more short of breath, or more chest tightness, heart racing, maybe numbness and tingling, like just these whole host of random symptoms, right? So that could be another version. There's even another version, which is more along the lines of, looks like you think you have a cold, or maybe you just got the flu, right? And those are like those constitutional symptoms, which we call like, chills, fever, headache, just body aches, things like that. That can also be a sign of post-exertional malaise. And that's more of the post-exertional neuroimmune exhaustion. So there's like a couple different versions of this. So again, bringing this back, it's really important to understand the central question, which I think helps people understand, do I have this or not, is, answering this question. Does exercise or activity positively affect you, right? And if the answer is no, then you really need to start thinking, okay, do I have post-exertional malaise? And if you're thinking that, then, possibly the next step is either doing it yourself or asking your physical therapist or your doctor to help you fill out the DePaul symptom questionnaire. Because this can help with identifying if you have post-exertional malaise for sure. But again, bringing this all back, like I was saying, it's understanding your version of PEM, right? Because there are different versions, different severities. So really knowing, okay, if I do something, how much later does it start to come on? Okay, so you know what window to watch for. And then, okay, it starts then, when does it peak and when does it end? Because then that helps you start to plan how to introduce movement, right? And I think that's the way to start off.
We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us. How do you class the sort of PEM that starts while you're still doing the activity? I mean, does that actually class itself as PEM, or is that something else? Because, there's definitely the thing where you sort of, you're going to walk to the post box and back, and you get there and you turn around to come back and uh-oh. So is that actually PEM?
Yes and no. So, by true definition, PEM is like a delayed onset, because by definition, post-exertional malaise, like after the exertion, you feel unwell. So during the exertion, right, if you're starting to feel unwell, it could mean that you are triggering PEM, right? And again, I think it depends on the person, because I've had some people that said like, oh, I took my niece out for a stroll just around the block, and it didn't feel good when I was doing it, but I didn't have a crash, right? You overexerted, but you didn't go into the point of PEM. And I think that's the thing that is, again, that gray area, right? That not every single time that you experience symptoms means that you're going to have a crash, or you're going to have PEM, right? However, I think no matter whether it's PEM or not, you shouldn't be feeling those symptoms when you do an activity, right? And I think that's kind of what can help us maybe segue into understanding why it's so important to avoid post-exertional malaise. And I don't know if you're familiar with this, but it was in January, there was a study that came out. It was titled Muscle Abnormality Worsens After Post-Exertional Malaise and Long COVID. It was by Appelman and colleagues, and it was a really great paper. And what they did was they took people who had long COVID, intentionally had them overexert. So intentionally, and then they took muscle samples to see what happened, and they took blood samples to see what happens. And we know that when post-exertional malaise is triggered, when you go to maximal capacity of exercise and post-exertional malaise is triggered, there are muscle abnormalities that happen, right? There is a catabolic breakdown, and there was even, examples of amyloid plaques building up. So we know there are physiological, chemical, and structural changes that happen, which is why it makes it so dangerous, and why there are people who get significantly worse, right, in response to exercise. Now, the interesting thing, this paper was super controversial. Like, it opened up, again, more conversation about exercise. And the thing was that one of the co-authors actually came out to defend it, because people were saying, see, this means you shouldn't exercise, right? And one of the co-authors came out to defend it and say that the study was not designed to study like the nature of submaximal exercise or subsymptom exercise, right? So it shows that there's danger of overexerting, but it didn't study what happens if you just do a very little in the range where you don't have symptoms. That's the sweet spot. And that's really what movement and exercise should be about. It should be about moving or exercising in a way that you're not bringing on symptoms, so that you're not causing physiological damage, so that you're not inducing post-exertional malaise, right? And so that's how I approach it with people. That's how I educate people. And that's really how people should approach it in general, regardless of whether you're intentionally exercising or you're just walking to the bathroom, right? Thinking about, am I doing something that is triggering symptoms? How can I stay below that level so I'm not constantly going into the level of overexertion?
Yeah, and I suppose this is in the same way that, we're using the word exercise and movement, but that could include, or, certainly be equal in some ways too, as you just said, walking to the bathroom, moving between your bed and your couch, going to the kitchen to fill up a glass of water, but also the cognitive side of things, which certainly for me was the one that tripped me up because I was so much less able to quantify it, where you read an extra couple of pages in your book and boom, you're actually sort of triggering the same response, but by doing something different, I suppose, aren't you? So whether it's an intentional movement or an intentional reading 2 pages of your book, or whatever, as a stupid example, it's doing it at a level below what is going to trigger you, is kind of what we're aiming for, isn't it? In everything.
Yeah, absolutely. And I think you bring up a good point that it really doesn't matter what the exercise is, right? If we're going to use that word exercise or movement, what matters is how you apply it. Because I mean, there have been plenty of examples of people who say, I love to dance, and I just do a little here and there, and it makes me feel so good, and like it brings me so much joy. I can't do like the big jumps or whatever that I used to be able to do, but I just do a little bit, and they find that through that they're able to improve and open up their window of tolerance. And then there's other people who say, I did the rowing machine, right? And then there's other people who said, I did some yoga. And then there's other people who say, I did walking, right? And so what's important here is it doesn't matter what the movement is, as long as it's something that brings you joy, fills your cup, is below the symptom threshold, and you follow these principles of treating it almost like a prescription in a way, right? And when we think about like medication or prescription, it must have a dose, an intensity, and a frequency, right? If you think about like a blood pressure medication, okay, frequency, I take it every day in the morning, okay? In, intensity could be the chemical compounds in it or whatever, and then the doses, I take 5 milligrams, right? Exercise is the same way. You kind of have to treat it the same, like a prescription or a medication. What is the dosage? Okay, it needs to be below symptom threshold, so meaning I can't go to the point where I'm starting to feel my heart racing, or I'm starting to feel brain fog, or things are starting to increase, a lot. Frequency, well, I know that my post-exertional malaise comes 2 days later, so I need to build in space for that to see if what I did, I tolerated it, right? So frequency could be once every 2 or 3 days. And the dosage comes back to keeping it sub-symptom threshold. So how much work does it take to stay below this threshold? And I think that's what changes every day, because you're going to change every day, right? And so your intensity, like you might say, oh, yesterday I did the rowing machine for 5 minutes, and my rate of rowing was, I don't know, 30 cycles per minute or something, right? So you're saying, oh, great, I can do 30 cycles per minute for 5 minutes. Well, then the next time you come around, you're a completely different person. And if you go to do 30 cycles for 5 minutes, you might overexert because your body is different that day. And so it's more about changing your intensity, right? So some days are slower, some days are a little bit more, to stay sub-symptom threshold.
We'll be right back.
Hey there, I'm just jumping in for a second to see if you're enjoying this episode. If you're finding it useful, maybe you would consider sharing it somewhere, a friend, a group, or even on your Twitter feed. If everyone was able to share just once, we'd be able to get this information out to even more people who really, really need it. So please consider sharing somewhere if you possibly can. I hope you enjoy the episode, and thank you so much.
Yeah, and I guess that's kind of the tricky bit, isn't it? Because if you use your prescription medicine analogy, it doesn't matter how you feel that day, you're still going to take your 5 milligrams of whatever it is. And, that's a done deal. It's just something you do every day. Whereas when we're doing movement here, well, I walked for 5 minutes yesterday, therefore I'm going to walk for 5 minutes today and 5 minutes tomorrow and 5 minutes the day after, and I'm going to do it at 9 o'clock in the morning because that's what it says on the box. It's not going to work like that because you may not feel able to do it at 9 o'clock in the morning, whereas you could do it at 2 o'clock in the afternoon. But also, as you say, the intensity and the length and all of those other things are potentially going to change as well. So how do we know how to judge that? I mean, there's going to be some trial and error, right? But also, ideally we would want to be able to, well, even, learn from those errors, if nothing else.
Yes, there is trial and error involved. And I think, that's something that you have to be comfortable with. So there are circumstances where, yes, there have been times when exercise has permanently changed someone's baseline, meaning that they did exercise and then they actually never came back to where they were before that exercise. And it happens. Right now, we don't know who or why, and so there is some inherent risk here in that I don't know if I'm going to be one of those people. I will say I don't know the specific percentage, except I do know it is lower than those who have a temporary decrease in baseline. So there is some inherent risk in that trial and error. And so that's why, yes, you do need to build in, okay, there's a chance that when I try this, it's going to make me feel worse. But from previous experience, I know that when I've done certain activities, it's temporary and I come back to a baseline and then I figure it out again, right? So yes, there is some inherent risk, and it's convincing yourself and understanding that it's temporary, right? For the most part. I can't say that for every single person. Again, I would love more research on knowing, some biomarkers. Hint, hint, anyone out there with a research lab. So here's the thing. The way that I usually introduce it with people, okay, is we establish a comfortable plan that the person feels good about, that they feel confident with, because really the first time that you introduce some type of a movement, it should be so small and so easy that you come out of it and you're like, did I even do anything? Right? Like, because you really just want to get that exposure and that rep under your belt that says like, okay, yeah, I can do this, right? You kind of have to convince your body and your brain, like, yeah, we can do this, okay? And so a lot of times I use heart rate to help with guiding people. There's guidelines from the Workwell Foundation, which puts out guidelines for ME/CFS in terms of understanding the anaerobic threshold limit. And not to go down like a whole rabbit hole of anaerobic threshold, but basically it's that limit of where you transition from using sustaining energy resources to short non-sustaining energy resources. So it's the difference between using the quick energy for a sprint versus like the energy for a marathon. Okay. And what we know is that people with long COVID and ME/CFS have a significantly lower anaerobic threshold. So that means that they switch over to their short reserves, right? Their sprint reserves much sooner than other people. And so they're just depleting themselves much faster. So anyway, so I use the information from the Workwell Foundation to set target heart rate zones for people. And what they basically suggest is no more than 15 to 20 beats above your average resting heart rate. And that sounds crazy because let's say your average resting heart rate is 70, okay? So then that means when you're doing activity, movement, or exercise, you shouldn't be going over 85 to 90, or you should be trying to stay within that window. And you're like, well, Meg, when I stand up and I get out of bed, I shoot up to 110. What do you mean I have to exercise or move at 85 to 90? That's not possible. But really what you want to do with exercise, it's how low can you go? Okay? It's not how high you can go. We know your heart rate can go high, no problem. That's not the issue. We want to train it to stay low. So it's how low can you go, right? And so that's why typically I start people off and I say, all right, we're going to do, I don't know, I'm going to give the example of marching. Lying down, picking up your legs or lifting your arms, and you're going to keep your heart rate below 85 to 90. And you're going to do this for maybe 30 seconds to a minute. And we start so low, but that person might have to wait for their heart rate to come down before they can start, right? So a lot of it is, what do I do before exercise and after? So you might have to lie down, put your legs up the wall, get your heart rate to come down, and then try the exercise. You might have to do breathing exercises before you do the intentional movement. You might need to eat a snack, to give yourself some energy reserves, right? So there's things you have to do as preparatory beforehand and then working in a really low threshold. Because again, it's about how low can I go? How can I keep my heart rate low? And you might have to move at the pace of a snail to do that, but that's where the magic happens.
So this is kind of like warming up before exercise, except it's almost the opposite, isn't it? It's where like instead of kind of like warming up so you can like go sprint, like actually I need to warm down. I need to down regulate myself so I can then do that exercise and
Yeah.
keep my heart rate below whatever my threshold is. It's like we were saying last time, isn't it? It's kind of like unlearning and relearning and doing things in kind of the opposite way round to what traditionally we might have done.
Yeah, absolutely. Because we learned that in order for exercise to be exercise, you have to get your heart rate up to get the benefits. And that's not the case here. Your heart rate probably goes up no problem, and that is the problem, right? And so what we actually need to train is we need to teach your nervous system and your heart rate to stay low and respond consistently to a normal workload, right? So in a normal exercise test, right? So like a treadmill test or a bike test or whatever, what they do is they gradually increase the intensity each minute, okay? And a normal response is that it looks kind of like this nice slope, if you can imagine like a hill, where as the intensity increases, your heart rate should proportionally increase. And that doesn't happen in long COVID. And so what we're doing is we're saying, hey, we're going to keep the intensity really low and we're going to keep it the same. And we're going to tell you, your heart rate and your heart, that you need to match us down here. And that's how you start to train your heart rate response. And that's how you start to open up your window of tolerance, is by saying, hey, I need you to meet me down here.
And I suppose, again, it's like a lot of other things where, the traditional model of whatever it is, whether it's breathing or nutrition or exercise, will say, right, okay, so it's progressive. So you do this, and then the next day you do that, and the day after you do that, and then you do that, and you just keep pushing yourself. And I mean, the end game here, I guess, is that we do increase our activity and that we are able to tolerate that. But I think what, people with long COVID as well struggle to understand. And I put myself in that category because I pushed myself too quickly. But also, particularly people who don't have long COVID and don't have the understanding of this, is that they sort of don't understand the sort of wibbly wobbly sort of non-linear progression, and I suppose how long you need to do a certain level and be happy and safe with that before you can then increase. But how does that look like? Because, yes, we want to increase. We don't want to increase too fast. We don't want to push people over the edge. And, understandably, there's going to be a lot of kind of anxiety around this as well. So how would you approach that?
I think in order to talk about this, we have to talk a little bit about the Levine protocol and the modified CHOPS, okay? And then also this term GET, graded exercise therapy. So graded exercise therapy is basically kind of like what you were describing, is like in those traditional normal, quote unquote normal, whatever normal is, right, models. It's, I do this and then I do this the next day and then I increase it the next day and then the next week I increase it, and you just keep adding on. Okay. And that is essentially what the Levine protocol and the modified CHOPS is, it's this 8-month long protocol where week 1, you do this much. Week 2, you do this much. Week 3, you do this much. It basically says that if you just keep increasing and progressing, then, you're going to work through it, and give yourself a few months, even if it doesn't feel good, to work through it, right? And that's actually not what we want to do here. And I actually don't use the Levine protocol or the modified CHOPS because, one, it's too aggressive, not only in where it starts off, but how it progresses. It doesn't build in space for post-exertional malaise, for monitoring for that. Additionally, it's designed to do intervals, right? you're supposed to increase your heart rate, decrease, increase, decrease. And a lot of people can't bring it back down. Like they're not trained to do that yet. So it's too hard. And additionally, it actually has a high rate of failure. I think it's like 50 to 60% failure rate in terms of non-completion. And honestly, that's because it wasn't designed for the masses, but it's being applied to just about anyone who kind of fits this POTS or dysautonomia presentation. And when we look at like the research studies for these protocols, they excluded people who had MCAS, MECFS, and like hypermobility disorders. So it's not made for everyone, and yet it's like as if everyone's using it because it's either being told that they should or affiliated with their similar situation. And so the thing is, it actually has a lot of great principles. Okay. And so I think understanding the principles will help answer your question of how do I move forward. And so the principles of the Levine protocol and the modified CHOPS is that you need to start horizontal and work your way vertically, right? Because if we are operating under the assumption that, at least more than 2/3 of long COVID cases are some form of dysautonomia, then that means you typically have orthostatic intolerance, meaning an intolerance to being upright. So if you're intolerant to being upright, you don't want to train in your triggering position. You have to start horizontal. Okay. So it's starting horizontal and then gradually working up to vertical. But like you were saying, how do you actually know how to progress and when and how much? So with the protocol, the rules, because there are rules, is that you need to do it a minimum of 3 times a week. Okay, because your body wants consistency and it craves consistency. So I use these similar principles is that the minimum is that you need to do it 3 times a week. Okay, and you may need to build up to that. Like you may need to start at once a week and build up to 3 times a week. But when you can do it 3 times a week without a crash, then you can say, okay, I think I'm ready to tweak this up a little bit. Okay. But honestly, sometimes, I have some people stay doing the same exact thing for a month, right? Because it's more about allowing your body to feel good and to adapt to the predictability of it than trying to add on, because you actually feel better by doing the same thing over and over again for a period of time. So often I'm like, just hold for one more week. Come on, hold for one more week. Don't increase yet. Come on, just hold one more week. Because I think there's more to be gained in not rushing that progression, right? So I think kind of as like a loose rule of thumb is whatever level or intensity you're doing, if you can do it 3 times in a week and you do not have a crash, right? Nothing has really changed, then you can look at slowly increasing it. And what I say is a safe percentage of increase is like 10 to 20%. So like, let's say if you were, whatever you were doing 2 minutes. Okay, let's say you're doing 2 minutes of biking. Then that would be adding on like, let's say about 20 to 30 seconds. So like 10 to 20% increase, it's such a small threshold that you can easily scale it back if you have post-exertional malaise. Whereas if you're like, oh, I'll add on another 2 minutes, well, how do you know if you would have tolerated 1 minute, 1 minute and a half, 30 seconds, 40 seconds, right? So 10 to 20% is such a small increase that okay, yeah, I definitely did too much. I'm not ready for that. Whereas if you do like a big window of 5 minutes, you have no idea where you could have tolerated that increase. So I think that gives a little bit of a framework, because again, this is a gray area. It's not black and white, but what I can offer is a framework.
And I think, it's always that less is more, isn't it? the motto that I always try to introduce into breathing, but I think it probably works here too, is that it's better to have been able to do more than to wish that you'd done less. It's much more comfortable to say, yeah, okay, well, maybe next time I'll try a little more than, uh-oh. Now, how does this work for people with long COVID who have fluctuating hormones? So, this is ladies of, what do you want to call it, reproductive age, or whatever the phrase is, which is quite a lot of people because, I don't know what the statistic currently is, but a large percentage of people with long COVID are female and are of that age. Because what we hear over and over and over is actually things are starting to go better. I have 2 weeks where actually things are quite good. I'm able to do a bit more, maybe I'm able to do a bit of activity and I feel good. And then I get into that week where my progesterone is high and oh my goodness, everything comes back. I can't do anything. So how do we kind of manage this within your structure? Because this is another one of those big fluctuations and we can't stop it from happening.
Nope, we cannot. So what changes is the effort, which is the intensity, right? And so during that, like we're talking about basically the luteal phase, which is right before menstruation, which is when females tend to notice that their symptom burden is much higher because of what you were explaining, those fluctuations in hormones. And so in that case, you still approach and attempt to do whatever it is that you're doing at that time, in your routine. It just may not take as much effort to achieve that heart rate zone or to stay low. You might have to do way less effort to stay below symptom threshold, to stay below that heart rate target. So what changes is your effort, essentially your output and your workload. The other thing is that you're probably during that time going to need more calories because your body is working extra in this luteal phase because it's basically either planning for a pregnancy or not. And either way, it uses more calories. So you may need more calories to then help sustain and actually have the energy in your tank to do that routine that you've been doing consistently. And then, of course, there is fluctuation because I'm saying that you need to do it a minimum of 3 days a week. Well, if you're at the peak, and you're really premenstrual and you're really having a high symptom burden, push it to the next day, right? As long as you're still hitting your 3 times a week, then you have that flexibility to move things around and say, you know what, maybe today is not the day, right? So I think that's really the way to approach it. Because again, coming back to your body craves predictability and consistency. So if you've been in a consistent routine, the worst thing to do would be to take the week off in that case.
Yeah, I mean, that makes a lot of sense. It's not that we stop, it's that we kind of listen to the body. And if the body's saying, okay, well, that feels very effortful, then we can sort of reduce that. And, I think, that's a lesson for life as well, isn't it? That in that week, I'm putting quotation marks around that week because we all know what it is, those of us who experience it. Actually, I think, all the advice is actually that movement does help. But it's going to be movement in a slightly different way. It's not hitting your PBs. That is not the week for hitting your PBs. It's a week for, doing more yoga and sort of going for a walk rather than a run kind of thing. So to put that back into your long COVID context, it's going to be gentler. It's going to be, maybe if you were upright, it, I suppose, is maybe potentially going back to being less upright for that week. Maybe I don't know if that would. No. Okay, you're shaking your head. No.
If you're in, you would stay in the same phase that you're in. You would essentially stay with the same activity. You would just put less effort and less workload into it to get the same results. Yes, because you want to keep your body working in the same position that you've been training in. But I think, another good thing to touch upon is there is a time not to exercise. And really that comes down to if you have an acute illness. So if you are sick, you should not be exercising, okay? So this actually means you have to stop whatever routine you're in. If you have a fever, you should not be exercising. Any of those things are definitely signs that you should not. If you are in post-exertional malaise, if you are in a crash, you should not be exercising. Those are like the top 3 things of when not to. Those are definitely like black and white. There is a lot of gray, but those are definitely black and white. And so when you reemerge, right, out of the crash or out of the acute sickness, you can't start right where you left off. You got to take it back significantly. And a lot of people, I think as humans, we're like, oh, I had a setback. Is it really though? Like, you might find that, okay, I may need to go back a couple of weeks, but you might be able to progress much faster than the first time. So I think that's important to know, is that there are times where you cannot exercise, and when reemerging, you can't just pick up where you left off, which is important.
Yeah, and as you emerge, I love that word, emerge. You emerge from your crash or your fever, because these are things that happen that we can't always avoid. Your partner's been at work and brings home something nasty. How do we know how kind of slow to take that? We take a few steps back, we go back a couple of weeks, we take it a little bit gentle. But at what point can we put our foot back on the gas? That's a terrible analogy here, isn't it? But, at what point do we start sort of thinking, okay, back on track kind of thing? And how do we know what that feels like?
I think it will come down to understanding your symptom burden. So when I use symptom burden, what that means is like taking like a temp check on all of your symptoms and how severe they are, right? Because the thing is, when it comes to starting movement and exercise and even going through this, you're not going to be in a place of no pain, no fatigue. And I use pain to cover any symptom that you experience, right? And I think that's hard for people to understand, is that a lot of people are thinking, well, I have to get back to 0 pain and 0 fatigue in order to start. And if you're waiting for that, you're going to be waiting forever, right? And so if you're reemerging out of one of these scenarios, right, there is no like formula to figure out how far back to go. You kind of have to just, not fully start over, but maybe think, okay, where was I about a month ago? I'd say that's probably a good way to look at it. Where was I about a month ago? Try that. And assess how your body reacts, and give yourself that space again for the post-exertional malaise if it is going to happen. But when I'm talking about symptom burden, what I'm saying is like, when you approach any type of movement or exercise, doing that temp check of like, all right, what's going on in my body right now and how severe is it, right? So, all right, I got a little bit of a headache, I'm a little bloated, I've got fatigue, I've got a little bit of some tingling, all this added up. If I had to say on a 0 to 10 scale, it's like a 4, right? I'm just throwing that out there. So that's your symptom burden. And then when you're actually doing the exercise, keeping in check of like, okay, is that what I started with increasing, right? And what I will say is that it's okay if it increases a little bit, okay? What I would say is that you keep checking in and giving yourself a score. Am I still at a 4 out of 10? Am I still at a 4 out of 10? Yes or no? Yes or no? When you get to more than 2 points above where you started, right? So if you're like, ooh, I'm at a 6, I'm about to be a 7, it's time to stop, right? So that will help to guide you too when you're reemerging, or even any other time, not just when you're reemerging, but any other time, so that you know when to stop and put on the brakes before just like, oh, 3 weeks ago I could do 20 minutes, but at 12 minutes your symptoms are increasing, right? It helps you put on the brakes and be able to avoid still as you're kind of reemerging and testing it out. And then, the other piece is, it's okay and it's normal after you move and have exercise to feel a slight increase in fatigue, a slight increase in your symptoms, as long as it doesn't impact your daily routine, right? That's a normal response to exercise. That's actually a healthy response, right? And I think because there's such this fear of post-exertional malaise, that when you're in that moment, any reaction is like, oh my God, I did it wrong. I'm having a crash. I can't tolerate exercise. And actually, that's a very normal response to exercise. It's just that the difference between normal and post-exertional malaise is post-exertional malaise impacts your ability to function, and it impacts your normal daily routine. So I often tell people, like, hey, the next day, expect to be a little bit tired more than your baseline. Expect a little bit increase in symptoms, but it shouldn't change the routine that you're in. As long as you can still get through your normal routine in your day, you're okay. And like, those are the things that you can use to self-monitor as you're re-emerging, but then just anytime in general.
Yeah, and I guess, it comes back to, the tools that we learn while we're recovering from long COVID or whatever are actually tools for life, because we should still be, checking in after we go for a 10-mile run, and oh gosh, I feel tired. Oh, well, that's okay. I would expect to. And, again, putting it back into the long COVID context, I did 20 seconds extra of exertion today compared to what I've been doing. Well, I would expect to be a little more tired. And I suppose it's that kind of like temperature check of what's normal, isn't it? And normal is a stupid word. And it's really difficult to work out what is normal when you've been in this world of being sick for so long, because, like your view of normal is so different to anybody else's and to what life was like before. So it's kind of difficult to work that out sometimes, isn't it?
Yeah, it definitely is.
Yeah. Well, thank you so much for coming back and for speaking to me again, putting yourself through this all over again. It's been an absolute pleasure. I think there's some really, really useful information there. I'll make sure that all of the links that you mentioned to things like research and guidance and things like that will go into the show notes so you can follow them up if that's useful. And thank you so much.
Yeah, great, Jackie. No, it was really a pleasure to follow up and I think make this conversation a little bit more complete. And, I just want to leave, your audience with a little bit something that, again, maybe you're in this moment right now where you're listening to the podcast horizontally, legs up in the air, and thinking like, how am I ever going to get out of this position? Literally and figuratively, am I ever going to be vertical again? And what I really want to share with you is that just because you might not be able to tolerate something right now doesn't mean that you won't ever be able to tolerate it. And there are steps you can take. There are things that you can do to help your body be in a better place to accept and handle more, whatever more is for you. So, I would really encourage anyone who's listening to this podcast to, check out my website. There's multiple ways that I can help guide people. And really just to hold on to perseverance, I think, more than anything. So thank you, Jackie.
Thank you so much to all of my guests, and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch